I would say 1/3 of my patients coming to me for headache evaluation. The most common question they come up as, do I have a tumor? Do I have a stroke? Lot of times I'll tell them no, even without a head CT, without a brain MRI. How do I know that? Vast majority of the headache are what we call benign headache or primary headache versus a secondary headache. Secondary headache is when you have a tumor or stroke or bleed that will give you a headache. Usually for those patients, they also have some other symptoms, what we call neural deficit, which means it depends on where the lesion is. It could be arm numbness, it could be leg weakness, it could be facial droop, it could be slurring speech. So that's one of the common symptoms suggestive there may be a lesion in the brain that we need to have take a picture of your brain. So vast majority, I would say 95% of the time when the patient comes just for pure headache, especially in young, healthy population, usually is what we call migraine. It's migraine. So what are the causes of migraine? If really try to pinpoint the cause, no one really knows. There are a lot of hypotheses. Someone say, oh, it's a brainwave irregularity. Someone say, oh, it's a chemical, and maybe there's a little bit more serotonin release. Someone will say, oh, there's a membrane, the lining of the brain get irritated. No one really knows what exactly it is, but it has been shown there are a lot of association or provoking factors to migraine. For example, sleep deprivation. If you not sleep enough for a period of time, you're more likely to have headache. Together with a lot of other cognitive symptoms, I'm more forgetful. My mind not as sharp as before. Stress. If in the Silicon Valley, we're in a very stressful location. A lot of professionals are working long hours and have a lot of stress from work, from different perspective of their life that can provoke headache. Dehydration. I often emphasize the importance of hydration in terms of treating headache. I frequently get called by the ER physician to evaluate or treat a patient with a severe headache. A lot of times the patient in the ER, they're holding their head, they couldn't move, they're crying, they're in tremendous pain. You know what we do to treating their headache? Instead of giving them painkiller, we give them one IV line. Sometimes we give 2 IV lines. We flood them with normal saline. It's just normal saline. It just flus. But a lot of times, occasionally we also give a little bit anti-nausea medication. But a lot of times we see their headache can be much better just after being hydrated. Of course, if you have headache and that moment you take a salty water or water, that won't help. But you really should keep you well hydrated all the time. For young healthy population, I would say not just pure water, because if you drink pure water, you have good kidney, you just pee it out. It doesn't really retain or enlarge your blood volume. We want you to drink something that has flavor. Drink something that has mineral or electrolytes in there, like Gatorade, like vitamin water or coconut water. They serve a very good purpose of hydration and also adding electrolytes in your in the body. Keep a regular routine. A routine means you sleep at the same time, you wake up at the same time, and you eat 3 meals at the same time. A lot of times the patient will tell me, oh, if I skip breakfast or if I eat a meal late, then I get headache. So identify those provoking factors, those triggers is extremely important in preventing headache. So for those patients who has done everything right, but they still have headache, so this is the time that we really need to use medication. So usually a patient come to me, they already tried over-the-counter medication like Tylenol, Motrin, Excedrin, and that doesn't seem to working well. Usually we say, and the neurology will say that those medications is really not target for nerve pain or brain pain or headache. And those is a really generalized painkiller. I always say if I have a cut, I take a Tylenol, and it seems to help for a couple hours, but it doesn't really address the issue on the cut. So when the patient come to me for headache, usually I give some prescription headache medication. It has a vast variety of different medication. That's the oral pill. It also comes in nasal sprays, especially for those patients when they have headache, they're already starting belching and vomiting. So this time, if I give you a pill, you won't absorb. So for those patients, sometimes I'll give you a nasal spray, sometimes under the tongue, or sometimes I will give a subcutaneous injection. It depends on how bad the headache is, how frequent, how severe, and also what insurance you have. So lastly, I also want to talk about the Botox for migraine. It is a FDA approved treatment for chronic migraine. And in my practice, it has been shown the far more effective than other medication than the oral pills. We all say the oral pills all have some side effects, make you drowsy, make us upset stomach. Sometimes it's stronger narcotic cause constipation, but for Botox, it's really just intramuscular injection. The mechanism is to quiet down the nerves, make sure the nerve does not irritation. So based on the location of your headache, we do injection on the front, on the forehead, top of the head, on the side of the head, on the back of your head, neck, and the shoulder. So this is served as what we call prevention or prophylactic medication. Usually one injection can help the headache control for 3 months. This is not a rescue therapy, but what I have seen is a lot of my patients loves it. This can replace all the other medication. Now certainly they don't need to go to ER anymore. Especially for even for elder patients, I still feel comfortable to use this because it's so safe. For a lot of painkiller, I wouldn't use because the GI, the upset stomach problem, the dizziness, side effects. In my practice, I have a lot of patients coming to me for snoring evaluation. So usually I will tell them 30-year or older man or woman will more or less having some snoring, making some sound during sleep. That's not something we need to be concerned about. But most important, we need to concern about is a condition called obstructive sleep apnea. What is obstructive sleep apnea? Let's first take a look at what happened in our airway during sleep. So this is a normal sleep. Okay, this picture. When we during sleep, the air goes in through your nose and go through your throat and go to your bronchus and the lung. The airway is completely open. When we fall asleep, our muscle relax. Why is that? Because the brain waves slow down. The brain's relax. The brain decrease control the body, and the body muscle relax, including the tongue and the soft tissue and the throat. So when those part of muscle relax, and then you are seeing the obstruction of this airway. So here the airway is blocked. When the airway is blocked, you don't get air going in. Of course, this is not gonna be forever. This is just a few. Sometimes I see a few seconds or 10 seconds or close to a minute. But when the airway closes off, you don't get enough air. The oxygen drops. That's when they send alert to the brain and the heart. The brain get alert saying, "Oh, I'm not getting enough oxygen. I need to wake him up." So typically during the sleep study, you will see when the airway closes off, the oxygen drops, and on the brain wave, you wake up, and we will see faster brain waves. This is a protection. Basically, the brain said, "I cannot go without the air," and then so you gotta wake up. In the meantime, when the oxygen drops, and the heart also get alert. The heart is thinking, "Oh, I'm not getting enough air. I need to pump faster." So your heartbeat can go faster, and then that add burden to your heart, because normal healthy sleep, your heartbeat should be slower than when you're awake. So a lot of times when doing sleep study, I see the patient with severe sleep apnea, their heartbeat can be 100. So I joke with the patient that you're not resting on bed, you're running a race in bed. A lot of patient doesn't understand. Well, what do you mean by that? Because your heart could not rest. Your heartbeat is fast. That's really adding burden to your heart, of course, and the brain, as we talk about. So that sleep apnea, well, the immediate effect is if you're tired the next morning, you don't feel restorative, dizziness or dry mouth. Some patients even have cognitive complaints. They will say, "Oh, my mind not as sharp as before." But more importantly, as a clinician, we concerned about is more the cardio and the cerebral vascular disease. Means when you have severe sleep apnea, your risk of develop high blood pressure increase. Your risk for develop heart disease and stroke increased. So that need to be treated. Talking about the treatment for obstructive sleep apnea, the first line and the most common treatment that we use is called CPAP machine, or continuous positive pressure therapy, CPAP. So in front of me, there are 3 masks. Where I want to say there are a whole variety of different kinds of facial interfaces. We only show the 3 here. So the mechanism is you put a mask on your face or on your airway, and then connected with the hose, and the hose is connected to, it's going to be longer hose, and the hose is connected to a machine. It's called CPAP machine, or it's a breathing machine. I usually call it blower because it's a keep blowing air into your airway. It's blowing a pressured air. Once you have pressured air going to your airway, your airway will open up because it has pressure, and then it will not relax. Your airway is not gonna be relax or obstruct, and then you are not having any apnea or stop breathing. So different patients that they really need to give a good try on the mask, because everyone, we look different, our facial structure different, the way that we breathe is different. Someone breathes more from nose, someone breathes more from the mouth. So we based on your facial structure, based on your breathing pattern, that we select a comfortable mask for you. So getting used to a mask, it does take a time. My experience is patient who has more severe sleep apnea getting used to CPAP much faster, easier than patient who have mild sleep apnea, because they can notice a benefit or significant benefit early on, or more prominent. I frequently have patients telling me, "Oh, after 2 nights use it, I feel I don't have dry mouth anymore. I feel more energetic during the daytime." So those would enhance them to keep using the CPAP machine. Having said that, everyone can get used to the machine and just need a learning process or a habituation. Sometimes we do some what we call desensitization strategies to have the patient get used to wearing this during sleep without taking it out in the middle of sleep. So this is the most common treatment, and then other treatment would be ENT surgery. Basically involves a surgery or operation that if you have crowded airway, let's say you have big tonsils, or lots of adenoid tissues, that the ENT colleague can do a surgery, remove tonsils, to trim the uvula or remove the adenoids, open up your airway. That will also help you breathing. The nose surgery for someone who tend to have a nose congestion or enlarged turbinates, and then trim the turbinates or straighten the septum, the middle bone of the nose, and also can help your nasal breathing. So another treatment options that we usually use is called oral appliance. Oral appliance is like a dental guard. It looks like just like what you use for teeth grinding. And when you put it on, and then you will protrude the lower jaw forward, and then open the airway on the back. So that would help mild sleep apnea as well. Usually, I would recommend that treatment, the oral appliance treatment, to young patients with mild sleep apnea. Besides those treatments, we're also frequently talking about supplemental approaches. Most importantly, I will tell patients that you need to lose weight. Lose weight will definitely help you with sleep apnea. And another thing is separate the bedtime and the sleep time at least 4 hours. And by doing that, and if you don't want to go to bed with a full stomach, because if you still have a big stomach, and then when you go to bed, that will not only gonna push on the lungs and make the lung now easier to inflate and affecting your breathing, and also frequently when you lie flat with a full stomach, you are easily having reflux disease that will also gonna affect your breathing. Sleep position change, and we always recommend patients sleep on their side rather than sleep on their back, because that also can help your airway, maintain the airway open.